classes. This is the 51st class of the series, and we have completed 1 year of online PG classes. Today we have got very eminent speaker with us, Dr. Sheila Nainan Myatra, and she shall be talking on a very important topic, which is very useful in our day-to-day practice, managing an unanticipated difficult airway. Definitely, you will be able to see this recording on ISA website also, on isaweb.in, in the ISA Academics tab, and on our ISA YouTube channel, ISA NHQ. I have with me Dr. Monica Chikara, who is the coordinator for today. And I'm very happy to share that right now I am in Lucknow in an MD exam, and I bring with myself greetings from Major Dr. Sanjay Chaube, Colonel R.K. Tripathi sir, and with my other co-examiners. So everybody is conveying best wishes to all the delegates. Over to you, Monica.
Thank you, sir. Thank you so much. So I welcome you all to the ISA online PG classes. And today we all have with us Dr. Sheila Nainan Myatra. Ma'am is a professor in Department of Critical Care Medicine in Tata Memorial Hospital, Mumbai. She's president-elect of Indian Society of Critical Care Medicine. She's chair of Intensive and Critical Care Medicine Committee of the World Federation of Society of Anesthesiology. She's past president of All India Difficult Airway Association. She is amongst the 14 international experts on American Society of Anesthesiology and Project for Universal Management of the Airway for Difficult Airway Guidelines. She is appointed on the International Surviving Sepsis Campaign Research Committee and COVID Guidelines. She has led the development of WHO oxygen algorithms for different resource settings through WFSA. She developed a new test in hemodynamic monitoring called the Tidal Volume Challenge. She's a member of editorial board of Anesthesia, Canadian Journal of Anesthesia, Journal of Critical Care, Journal of Critical Care, Anesthesia, Critical Care and Pain Medicine, Trends in Anesthesia and Critical Care, Airway, JOACP and IJA. She has been awarded FCCM by American College of Critical Care Medicine and FICCM by Indian Society of Critical Care Medicine. She has over 120 indexed publications and over 40 book chapters. It is a proud privilege to have you, ma'am. So during the course of this lecture, all the participants will be muted, and the queries or any questions the participants are having should be typed in the chat box. The questions madam will be asking during the course of lecture, the answers to those should be typed in the chat box. So
Thank you, Monica, for the warm introduction. Now I hand over the podium to Madam Sheila Nainan Myatra. Monica, you are the host now.
So, I hope you can hear me and you can see my screen.
Yeah, ma'am. Right. Sure.
So, good evening, everybody. First of all, greetings from the Tata Memorial Hospital. At the outset, I'd like to thank the Indian Society of Anesthesiology anesthesiologists for inviting me for this very important online PG teaching program. I'd like to congratulate the ISA for completing 1 year and conducting this online teaching, in the midst of a pandemic. Especially the president, Dr. Venkatagiri, and the general secretary, Dr. Naveen Malhotra, and the entire team for this great initiative. And I wish to thank Dr. Naveen Malhotra for inviting me to speak on a topic that is very dear to my heart and also a very, very important topic for anesthesiologists. Now, airway management is one of the core competencies of an anesthesiologist. And one of the most dreaded things is to face an unanticipated difficult airway. So what I'm going to do over the next, say, 40 minutes is I'm going to put you through what are the different settings, of facing an unanticipated difficult airway, the guidelines that we have come across, compare them with the international guidelines. And if time permits, I would also like to put you through some cases so that we have a nice practical case-based discussion. The objective is not only to prepare you for an examination, but really to prepare you for your career and your profession as an anesthesiologist when you go about dealing an unanticipated difficult airway, and to update you with the latest developments across the globe in this very important topic. So thank you once again, and I will start my presentation now. And if there are any questions as you go along, please put them in the chat, and I hope Dr. Monica will assist me with any queries. Stop me as I go along, and if you remember anything at the end, also put your questions in the chat, because I would like this to be as interactive as is possible. So here coming, look at this cartoon. So, you know, I really like this cartoon very much because, you know, this is typically a setting which you face when you are in the operating room and you deal with an unanticipated difficult airway. And look at this, look at the airway operator, you know, pasina chut raha hai. Just look at this. Cannot intubate this patient, cannot mask ventilate, and look at the saturation, and look at the heart rate. Okay, and look at the assistant. The assistant is almost frozen. So this is a situation that we all dread. We think it's never going to happen to me, or it's not going to happen to me today. That's the confidence with which we enter the operating room when we have to give general anesthesia to a patient, or you have to intubate the patient. And if you look here, even the assistants, you know, even the sweeper is kind of looking perplexed because everybody knows something is very wrong, a very grave situation. And this is the situation that as anesthesiologists, we're always afraid of. And I would say, why do you want to face this situation? We should try to prevent this situation. And if we can't prevent this situation, then at least we should be very well prepared to deal with this situation. And that's what my presentation is going to be about, is how to manage an unanticipated difficult airway. So first, let's just talk about a difficult airway. Now, the ASA defines a difficult airway as a failure to complete one of, so there are different, sequential steps in upper airway management. So failure to accomplish any of these steps is called an unanticipated difficult airway. So you might have a difficult face mask ventilation, it may be a difficult laryngoscopy, or a difficult tracheal intubation, or you may have a completely failed intubation. So any of this could constitute a difficult airway. When you tell someone, I've had a difficult experience of difficult airway with the patient, it's not only about passing the tube. Now, difficult mask ventilation can also be present, and we have various mnemonics to identify, potentially difficult mask ventilation. And the incidence is relatively low. And difficult tracheal intubation and a completely failed tracheal intubation. Now, these are some of the series, but again, this is, literature from across the globe in different areas, depending upon your setting and your expertise, these rates might be higher or lower. So very important that if we could predict a difficult airway, then we would be really well prepared and we would do that airway away. So let's see how good are we at predicting a difficult airway. Okay, are we good at that? So if you look at this Cochrane review, okay, now this Cochrane review was performed recently, 133 studies and almost 844,000 participants. And what was the conclusion of this Cochrane review? That the classic bedside tests all of us have taught and examined, that were examined in this review, actually showed that they're not well suited for detecting unanticipated difficult airway because they miss a large number of people who have a difficult airway. Now, ideally, when you have a test, the test should have a very high sensitivity because you don't want to miss anyone who's a difficult airway, right? But what they found in the Cochrane review is that all the investigated indices had a relatively low sensitivity with high variability. So the standard bedside examination tests, we should interpret them with caution because they don't appear to be good screening tests. And among the various tests that were studied, it was the upper lip bite test. I'm sure all of you are aware of this test that showed more favorable diagnostics. Now, there's another study that was more recently done, and this was looking at 62 studies. This was published in one of the JAMA articles, and it was looking at, will this patient be difficult to intubate, and how prepared are we to identify this? And they concluded that although there are several clinical fact findings that are useful for predicting a highly likelihood of a endotracheal difficult tube, no clinical finding reliably excludes a difficult intubation. And they also found that the upper lip bite test, which is easily assessed by clinicians, raises this probability of a difficult intubation from say 10% to greater than 60% for an average risk patient. So when you look at a patient with trismus, or you look at a patient with some facial anomaly, I mean, these are going to be difficult. We are talking about how good are you at predicting someone who has an average risk patient who looks normal, whether you're going to have an unanticipated difficult intubation in these patients or not. So, coming to this kind of literature review, you really don't have any of the tests that can, really predict and tell you, yes, for sure, this will be a difficult airway. A combination of tests may be better. And among the tests that we have, the upper lip bite test is the one that has, which is, it has the highest probability of assessing a difficult intubation. So does that mean that we don't do our pre-op assessment and airway assessment? No, that's not right. We should do it, because definitely it gives you some objective assessment about the airway. It prepares you. For example, if I know the patient has trismus, I know that if I, am unable to ventilate this patient or something goes wrong, I know I can't put in a supraglottic airway device, and I have to go directly into doing a cricothyrotomy for this patient if I fail the airway. So it's very important to do it. But what is most important is to do, of course, use your conventional tests for difficult airway assessment, but always be prepared that even though the test has predicted that this will not be an anticipated difficult airway, any airway may be a difficult airway, and you should be prepared to manage an unanticipated difficult airway. So that's the real message from this. And for this, we have guidelines. So what do we mean by guidelines? So what is a guideline? A guideline is a statement which is used to determine a course of action. So it basically aims to streamline particular processes according to a set of routine sound practice. So remember, it's not a law. Following a guideline is never mandatory. Guidelines are made to make the actions more predictable and presumably of higher quality. So they're evidence-based recommendations that we have for these guidelines. And I'm very proud to say that in 2016, we have the Indian Guidelines for Difficult Airway Management, which were published in the December issue of the Indian Journal of Anesthesia. And this is not just a rehash of the existing guidelines or a cut copy paste job of the other guidelines. They're really, really good content in the Indian guidelines that we should be very, very proud of, because a lot of the international societies have implemented a lot of points that were incorporated in the Indian guidelines into the universal guidelines. And what we did is we didn't publish just one guideline for the adult. We published guidelines for obstetrics, guidelines for pediatric, guidelines for extubation, and also for the first time in the world, guidelines for management of tracheal intubation. So all these 5 guidelines were published simultaneously in the Indian Journal of Anesthesia in the December issue in 2017. But I'm going to be speaking to you about the adult guidelines and what are the recommendations for the management of the unanticipated difficult airway. So these are the guidelines that were put together by the All India Difficult Airway Association in 2016. I'll just tell you a bit about the process. There was a committee of 14 experts. We did a very robust literature search. It wasn't just taking articles, a very good literature search. And this was presented at the national meeting. And then we also had several gray areas where evidence was lacking in the literature. So recommendations was made by consensus. We also put out a questionnaire which was circulated and put up on the website of the society, and we had several respondents, and based on the consensus we further drafted the guideline, and finally it was reviewed by overseas experts, and the final draft was presented at our national meeting, and it was published in December 2016. I won't go into details of a literature search, but a very robust literature search was conducted. Almost 15,000 abstracts were reviewed, and finally we brought it down to 766 articles. And we also looked at the guidelines of various societies, and they were reviewed. And we were very fortunate because we came up with guidelines after the DAS guidelines. So there were several lacunae in the DAS guidelines, so we also reviewed this content and tried to improve them better in the 2016 guidelines. And again, there's a disclaimer. Like I told you, guidelines have been developed to help clinicians manage unanticipated difficult intubations in patients using evidence-based recommendations. Guidelines do not represent the minimum standard of practice, and nor are they a substitute for good clinical judgment. So when you're in a difficult situation, if you know the guidelines, it can give you the most evidence-based approach to tide over the situation. But remember, you have to use your good clinical judgment. It cannot be that this, a guideline can replace that at any point. And that's what's very important to realize when you follow the guidelines. Now, what do the adult guidelines look like? Now, if you look at, it's a vertical pattern. It's pretty much, if you have seen the Difficult Airway Society guidelines, it's got a similar kind of vertical content. And I'll put you through this. And what's most important, in a stepwise manner. So very simple on a single page. I won't put you through the pediatric, obstetric and other guidelines, but they're very similar. All we've just used different color coding and subtle differences in specific aspects related to obstetrics, pediatrics, so that it becomes very easy for anybody to remember whether they're doing an obstetric patient or they're doing a pediatric patient. Now, just to start with, I'll go through the first step. Now, whenever you are faced with an unanticipated difficult airway, and that's supposing you're doing a tracheal intubation, the first thing, of course, that you must do is to call for help. This is the most important thing. The first episode of difficult airway, you must call for help. Now, what do we mean by, in the step one? Like, you might be intubating, irrespective of what you're using. Are you using direct laryngoscope or you're using a video laryngoscope? Do not continue with more than 2 attempts. And what's more important is to mask ventilation between attempts. What people tend to do, for example, the DAS guideline says 3 attempts at intubation. It doesn't mean that you have 3 lifelines and you just go on intubating the patient. You must make sure that the saturation is up between attempts at intubation. And this is an important aspect that the IDA guidelines emphasizes on, that only if the saturation is more than 95, mask ventilate between attempts and optimize your position. So it's very important that when you first fail your intubation, call for help, but try to optimize your attempt. So the next attempt should not be the same thing. You should do something to improve your success of tracheal intubation. So optimize your position. Okay, use external laryngeal manipulation. Release your cricoid pressure. Use some tools. Use a bougie, still it. If you started with a direct laryngoscopy, change over to video laryngoscopy. So at each attempt, you should do something, not the same thing again and again. I use the same direct laryngoscopy and I'm doing it again for the second time and again for the same. Take the blade, change the blade. Maybe use a McCoy blade, use a video laryngoscope, change the operator, change the device, change the tool, change something. But your next attempt must be an effort to improve your success with the tracheal intubation, right? So a very important, change device, technique or operator between the attempts. So you have 1 failed attempt and an additional 2 more. But what's important is throughout this, maintain depth of anesthesia, because sometimes if you're taking time, then your patient may have become light. You may have to repeat some propofol and, even repeat neuromuscular blockage. So it's very, very important that you maintain depth of anesthesia, because we don't want, awareness. Now, a very important part of the Indian guidelines is that we talk about peri-intubation oxygenation. It's one of the first guidelines that gives a huge emphasis on peri-intubation oxygenation. In fact, we recommend that you should give nasal oxygen during attempts at tracheal intubation. And how do you give this technique that we call no DSAT? Nasal oxygen during efforts at securing a tube. That is what no DSAT stands for. So using your conventional flow meter, you give 15 liters of oxygen. So even you've already pre-oxygenated the patient with 10 to 15 liters of oxygen, and then you continue apneic oxygenation after giving the muscle relaxant using your nasal oxygenation, which will further prolong the safe apnea period. Now, what do you mean by safe apnea period? Now, the safe apnea period is the time from the time you give the muscle relaxant to the time of desaturation. Now, if you have pre-oxygenated your patient well for at least 3 minutes, you have about 5 to 8 minutes before the patient starts desaturating. However, if you give nasal oxygen during attempts at intubation and you've pre-oxygenated the patient well, you can prolong the safe apnea time up to 12 to 15 minutes. And if you're using high flow nasal oxygen, you can prolong it up to 30 to 45 minutes. Now, this is very important because in case you have an unanticipated difficult airway, you actually have more time. In fact, techniques like Thrive, where you're using high flow nasal oxygen, which can prolong your safe apnea time to 30 to 45 minutes, have actually resulted in a paradigm shift in the way we're looking at difficult airway management. From this hurried kind of thing where you cannot intubate the patient and you cannot ventilate the patient, you're trying to do an emergency cricothyrotomy. Here, your patient's saturation is preserved for longer periods of time. Patient does not desaturate till 30 minutes to 45 minutes. So you can actually do a neck rescue in an unhurried fashion. And this is the advantage of using these techniques. So definitely you should use peri-intubation oxygenation, do good pre-oxygenation. But when you have an anticipated difficult airway, this is definitely the part where you should definitely use apneic oxygenation, using nasal oxygen during attempts at securing a tube, whether it is just your simple nasal cannula with 15 liters of flow of oxygen, or high flow nasal oxygen, that's Thrive, if you have that available, should be used, especially if you're anticipating that will be difficult. So this is what you do when you fail intubation. Remember, not more than maximum 3. Your 1 failed attempt and 2 more attempts, and do something different in each attempt and maintain the depth of anesthesia. Now, if you succeed in your, say, second attempt or third attempt, what's very important, and we have emphasized this and we were criticized for this, but it's very, very important that you have to confirm tracheal intubation using capnography. And what do we mean by capnography? We are talking about waveform capnography. The Indian guidelines are the first guideline that doesn't just say capnography. As I'm, what I'm showing you is just the algorithm. You have to read the text along with the algorithm to understand the nuances and little detail. So just a word, because you're all PG students here, you have to use waveform capnography. There's also colorimetric capnography. You can auscultate, you can look for chest rise, but the gold standard is waveform capnography. And remember, do not react to a single trace. Whenever you intubate a patient, look at the capnography. Sorry, the capnography waveform, there should be 5 to 7 consistent waves with no decline. This is the language. 5 to 7 consistent capnography waveform with no decline. And I'll tell you why this is very important. If you have a difficult mask ventilation, okay, you'll see a lot of air goes into the stomach. If you have an esophageal intubation, in the first 1 or 2 ventilation that you give, there will be some CO2 coming out. So you will see a capnographic trace. So never respond to the first capnographic trace and say the tube is in. Look for 5 to 6 traces, because if this tube is in the esophagus, you will see a decline in the capnography trace and it becomes flat. And this can often be a problem when you just respond very quickly and later you realize the tube is in the esophagus. So make sure you have 5 to 7 consistent waveform of the same amplitude and there is no decline, and then only should you say this is confirmed tracheal intubation. So this is very important. We've had 2 recent deaths in the UK because of missed esophageal intubation, and this should really never be a never event. The gold standard is to use capnography. Okay, so now if you did your 3 attempts and you could not intubate this patient, then of course this is a failed intubation. And what you need to do is resume mask ventilation with 100% oxygen. Remember, even between the attempts, you should get the saturation up. The saturation has gone down to 80 at the first attempt. Don't go to the second attempt till the saturation comes up. Then what do you do in the next step? Coming back to the algorithm, we've just finished the first part and you've called for help. And then what you do is the rescue is to insert a supraglottic airway device. Now, this is very important. That supraglottic airway device, unfortunately, is very underutilized. It's used for anesthetic, but very less as a rescue. When you fail intubation, don't go on and on and on intubating the patient. Now, why do I say don't go on? When I was a PG student, it was a very intubation-centric airway management. Somehow you had to get the tube in. And the professor who could get the tube in was like a hero. Today, we've moved away from, just fixation on getting the tube in into safe airway management practices. And the reason we don't want more than 3 attempts at intubation is because when you go on having repeat attempts at intubation, you have the potential to cause airway trauma. Your airway can deteriorate. You can convert a can ventilate situation into a cannot ventilate situation, and you might be in a catastrophic situation. So you shouldn't go on and on doing airway instrumentation. What you should do is try to oxygenate this patient, try to ventilate this patient. What is very important to remember is not intubating will not kill a patient, not ventilating and oxygenating will. So at all times, maintain oxygenation, try to ventilate the patient in whatever way, and it doesn't have to be an endotracheal tube. So when you have 3 attempts You've done 3 attempts and you failed. Do not intubate further. Insert a supraglottic airway device. And remember, continue your nasal oxygen if you've been using it, because this can prolong your apnea time. Now, preferably use a second generation anyway. Okay, supraglottic airway device. And why second generation? Now, what do we mean by a second generation? Now, the classic LMA. Can anyone tell me what is the ceiling pressure of the classic LMA? Can you put it in the chat box, please? Monica, if you can tell me the answer, because I can't see it. Yeah. So can anyone tell me what is the ceiling pressure?
Pressure of classic LMA.
Yeah.
Kindly type your answers in the chat box. So Dr. Chandrabhan is saying 20, Dr. Divya is saying 20.
Yeah. Okay. So that's the correct answer. Okay. And can anyone tell me what are the 3 characteristics a second generation supraglottic airway device should have? There are many tools there are many devices today in the market, but to call it a supraglottic airway second generation, you should have 1, 2, 3. Can anyone just type very quickly? You can tell
Dr.
me.
Nina has said gastric drain.
Yes. Second was a hint from my first question.
Pressure.
Okay, but what pressure?
Dr. Mohammed has said pressure, and seal pressure is 30, Dr. Divya.
Okay, and third? When you look at a second generation, you will always see this particular characteristic, which is not there in the classic element. Anybody? Okay, all right. Okay, I go. So a second generation device, when you look, there are so many supraglottic airway devices. And after I finish talking to you also, there'll be 1 or 2 more manufacturers that say our supraglottic is better. When you look for a second generation has a gastric drainage port, okay, a tube. So through which you can pass a Ryle's tube, and it is used to decompress the stomach for gastric aspiration. Right. So this is one very important feature of a second generation. The second thing is the sealing pressure. The sealing pressure should be above 30 centimeters of water. And the third is all your second generation devices will have a bite block. Okay. So these are the 3 characteristics of a second generation. So you must try to use a second generation device. And the reason I'm telling you is not for the bite block, because they give a higher sealing pressure. Now, what do you mean by sealing pressure? Intracuff pressure is very different. The sealing pressure is what maintains the pressure in the cuff, maintains the sealing.
Sorry to interrupt you, ma'am.
Yeah.
The slides are not moving.
No, I'm not moving them. I'm just talking. Yeah. So the sealing pressure is very important, because there is intercuff pressure. There is a seal. Remember, the supraglottic airway device is not in the trachea. It doesn't, theoretically there is a risk of aspiration. So because there's an intracuff pressure, this pressure is exerted on the supraglottic area and creating a seal, and this prevents the aspiration. So the higher the sealing pressure of the device, the safer it is to protect against aspiration. So whenever you have a supraglottic airway device, always look at the peak inspiratory pressure. The peak inspiratory pressure should be lower than the sealing pressure of the device. So if I have my sealing pressure of the supraglottic airway device is say, above 30, I must always monitor the peak inspiratory pressure. And if the peak inspiratory pressure is lower, then it will not leak around the cuff of the tube and all the air will go into the trachea and there will be chest expansion. So the sealing pressure is very important, both for safety as well as efficacy. And that is the reason we recommend that try to use a second generation. But of course, if you don't have it, use whatever you have, use a first generation. And that is why we say preferably, because many places are still using the classic airway. With the supraglottic airway devices, we say maximum 2 attempts. Again, the same thing, only if the saturation is maintained, right? And mask ventilate between the attempts. You put in a supraglottic airway device, you couldn't ventilate, take it out, mask ventilate, bring the saturation up, and then put in the supraglottic airway device. And again, you must do something that will increase the success. Okay, I put in a Supreme, but it's not working. Put in a Proceed the next time. Change the operator, change the device. Don't keep doing the same thing again and again. And most importantly, maintain the depth of anesthesia. Now, if you succeed, now this is very important. What are you going to do if you succeed? Right? So you put in a supraglottic airway device, you've brought up the saturation, and now you have to consider one of the following options. So one of the options is, okay, I can postpone this case. If it's an ICU patient, I can't do that because I have to give them a definitive airway. But in the operating room, I can say, okay, this was a difficult airway. I want to plan better. I tell the surgeon, no, I'm going to wake up this patient. So you just bring them out of the anesthetic, come out of muscle relax and reverse them, and then you can just remove. So that's one option. But maybe your surgeon won't be so kind in today's time and they might say, no, we want to continue with the case. So depending what is the case and what is the setting and is safe, what is the kind of confidence level of your surgeon, and you, how fast is your surgeon, you can continue with the supraglottic airway device. For example, a simple breast surgery or some small surgery, okay, then I can continue with the supraglottic airway device. But if it is, say, an abdominal surgery, say it was a emergency surgery or an intestinal perforation or something like that, I can't continue the surgery with the supraglottic airway device. And now I need to have a tube in, right? Because I need a tube for the anesthetic. Now, very, very important, please do not remove the supraglottic airway device. You need to intubate through the supraglottic airway device. And remember, you need the expertise to do it, and you need to have a bronchoscope. Do not do blind intubation through a supraglottic airway device, and you must have the expertise to do this. And it's very, very important. The cases where people have lost airways, I've been part of these cases, is when a person has removed the supraglottic airway device and then they were not able to intubate, put in the supraglottic airway back inside. So when you're able to oxygenate a patient, do not create a situation where you lose that airway. Remember, even with putting a supraglottic airway device, there is a 3 to 6% failure rate of putting a supraglottic airway device. So once you have it in and the oxygen saturation is gone up, you will not be forgiven if you remove that supraglottic airway device. Say an expert comes in and you say, "Arey, just take out that supraglottic airway device, I'll intubate." You might be in a situation you won't be able to do it. So remember, whenever you put in a supraglottic airway device as a rescue, you must intubate through that. Irrespective of which supraglottic airway device you have used, if you have what we call an ion tree exchange catheter, you can intubate through any supraglottic airway device. What is that? That is like a hollow tubing, like a bougie, double, more than double the length of an endotracheal tube. And what you have to do is you have to slide it over a bronchoscope, like that. And then you put this bronchoscope through the ventilating port of the supraglottic airway device, right? So just imagine this situation. Sorry, I don't have an image, but you have your bronchoscope and you have this, you put this entry exchange catheter, which is like a hollow bougie over the, bronchoscope. And you guide this into the trachea through the supraglottic airway device. Now, once you've identified the trachea, what you have to do now is you remove the bronchoscope. Okay, so you remove the bronchoscope. So what you have is this bougie in the trachea. Then you deflate the cuff of the supraglottic airway device. You remove the supraglottic airway device. So now what you have is the entry exchange catheter in the trachea, over which you can guide any size tube of any diameter. Right? When you try to intubate through a supraglottic airway device, you are limited by the size of the device and the type of device. For example, imagine if you've seen a Supreme, it's very difficult to intubate through that, right? So by using the ion tree exchange catheter under vision, you are able to put an endotracheal tube, intubate this patient and put it differently. The point I'm trying to make is that never remove a supraglottic airway device that you put as a rescue, with which you've been able to achieve the oxygenation. Always intubate through the supraglottic airway device. Get someone who has the expertise to do it. You have time, right? You have a supraglottic airway device, saturations come up, get a bronchoscope and get an expert. There is no hurry to intubate this patient. In a very remote setting where you have no option and it's an emergency surgery, you might even consider the surgeons available doing a tracheostomy. So these are the 4 options that you have when you have put in a supraglottic airway device. Now, if you fail, like I told you, even a supraglottic airway device can fail. So you failed intubation, you failed, ventilation. Then what do you do? Now, the next step is very, very important. And this is what we call rescue face mask ventilation. So what we're doing is, this is one last attempt to ventilate this patient or oxygenate this patient. What you do is you continue the nasal oxygen, of course, and you ensure neuromuscular blockade. Now, this is very, very important. People say, "Oh my God, I can't intubate this patient. Why will I give neuro?" So there's a paradigm shift in the way we're looking at airway management. So if the patient has been given scoline, they might have been come out of scoline now, or so you might have to repeat a dose, a long-acting relaxant, or you already have a relaxant and you've taken a long time, repeat, make sure you ensure neuromuscular blockade. And then you try one final attempt at face mask ventilation. And this should be your best attempt, a 200 attempt, along with an assistant, somebody else bagging the patient. So use adjuncts, use an airway, nasal airway, oral airway, whatever, but your best attempt. And invariably, when you give muscle relaxant, you decrease the chest wall compliance, you're able to ventilate this patient very well. And if you're able to do this, so this is your last rescue face mask ventilation. And if you're able to do this, there's no question of proceeding with the surgery, but you just wake up the patient. Now, why neuromuscular blockade? Now, look at this situation. you are in a situation, a rescue situation, where your three lifelines, what are the three lifelines we have to ventilate and oxygenate the patient? We have mask, we have a tube, and we have a suprachoroidal airway device. So all three, if they have failed, their suprachoroidal airway device has failed, your endotracheal tube has failed. So this is your last attempt to check whether your mass ventilation will work. So the chance of success is highest if you use a neuromuscular blockade, and that is why you recommend to do a neuromuscular blockade. Now, despite your best attempt and complete neuromuscular blockade, if you still aren't able to ventilate the patient, you are proceeding towards what we call the last step, where you do an emergency cricothyrotomy. And this is a procedure you've probably never done in your life, or you must have done just once in your life. And the chance of success is when you have a completely paralyzed patient who's absolutely still. So you're with your back against the wall in this situation, and your only option really, and your best chance of success, if you give muscle relaxant to this patient. So unlike what I was taught when I was a trainee, don't paralyze the patient if you can't ventilate them. And, there's been a paradigm shift in the way we are looking at airway management today. Now, this is a situation that we call complete ventilation failure. And this is a new terminology that we've coined in India called complete ventilation failure. And I'll tell you why this is a very, very appropriate terminology. And this is probably where we differ from the Difficult Airway Society guidelines, which call it CAICO, cannot intubate, cannot oxygenate. And another very unique feature of the Indian guidelines are calling for additional help. Now, why do we call for additional help? Initially, you called for help when you could not intubate because you wanted help to come, you wanted an airway expert to come. The reason to call for help here is not only to have an extra hand, but also because at this time, you know what happens to you at this time? Your hands are shaking, your heart rate is high, your blood pressure is high, you're not thinking straight. There are a lot of human factor consideration. There's cognitive overload, you lose sight, you have tubular vision. There's a lot of things that are described, a lot of human factor consideration. So the other person who comes in, who's not part of all this, not only an extra additional help, but is someone who's not part of the situation, can think straight and will tell you, oh, why don't you just do this? Oh, why don't you do that? And it might be just the junior most person in your team, but they might be able to help you better than all the people in the team who are already very, very stressed. So calling for additional help is not only for technical help, but also for to overcome the human factor considerations that occur very much during this time. Now, coming to complete ventilation failure, what do we mean by complete ventilation failure? So complete ventilation failure is essentially a situation where intubation, ventilation using a suprachoroidal airway device, and a face mask have all failed despite the best effort, and even if the oxygenation is maintained. Now, this is very important, because when you want to do an emergency cricothyrotomy, that is the last step, you don't want to do it when the saturation is 80, 70, 60. So the real question is, when should you be doing a cricothyrotomy? When the saturation is 100, but you know that this is going to fall in some time, or you want to do it after the saturation is fallen. And that is why the term cannot oxygenate is not an appropriate term anymore, because your saturation may be preserved, but this is the time that you need to do a cricothyrotomy rather than wait for desaturation. And in the era of apneic oxygenation, you might be able to preserve your oxygen saturation for longer periods of time. But that does not mean that this is not going to fall. How long it's going to fall really depends on the individual patient and what level of pre-oxygenation you have given to this patient. And therefore, cannot oxygenate in the era of apneic oxygenation becomes a misnomer and is not the right terminology. And cannot intubate, because intubation is not the only way to maintain oxygenation. So that therefore we don't say cannot intubate, cannot oxygenate. And the international airway community has challenged this terminology, cannot intubate, cannot oxygenate. And they really appreciated our terminology of complete ventilation failure, because what we're saying is intubation failure, ventilation failure precedes oxygenation failure, and that should be the trigger, not the oxygenation failure. So what we recommend is proceed to emergency cricothyrotomy when there is complete ventilation failure. So when the oxygen saturation is maintained, and not when hypoxemia sets in. This is really, really very, very important, because when you ask a lot of people, when will you do emergency cricothyrotomy, they will tell you when the patient starts to desaturate. And that's actually the wrong time to do it. You should start doing the cricothyrotomy when the saturation is preserved, because you are less stressed. You know what happens when you hear that pulse oximeter tone and the saturation going down, and you're doing a procedure you've never done in your life for the first time. You're definitely much more confident doing it when the saturation is 100%, and you know that the saturation is going to fall down at any time. So that is the reason why we call it complete ventilation failure, because all your three lifestyle lines have failed, and that is why the term complete. And I mentioned calling for additional help. So now we come to the final stage when you reach complete ventilation failure. And what do we do in this kind of setting? We have to proceed with what we call an emergency cricothyrotomy. And this is very important. You continue the nasal oxygen again. If you've been using nasal oxygen, do continue that and perform any one of the techniques. The DAS guidelines here again mentions surgical cricothyrotomy. They mention the scalpel bougie technique. What we have recommended is you can use any of the three techniques available. Either do the scalpel bougie, which is surgical cricothyrotomy, or use, you have ready cricothyrotomy kits. You have other sets that are available in the market, or you can use a needle cricothyrotomy. But for those who use needle cricothyrotomy, people like needle cricothyrotomy because they're very familiar with the Seldinger technique, etc. But remember, it's not enough to just put the needle in. You need to have pressure regulated jet ventilation and need to keep the upper airway patent. Now, this is very important. So if you don't have jet ventilation, there's no point just putting a needle inside. The reason we have kept with all the three techniques is because this is a very rare situation. There's very, very less evidence for this thing. The NAPFA project actually showed higher failure rate with the needle cricothyrotomy, and that is the reason they recommend scalpel bougie. But considering the Indian setting, where people have never done this, whatever you are familiar with, you should do. But what is most important is to make sure that you transition into doing emergency cricothyrotomy, whichever technique, and maintain ventilation and maintain oxygen. This is very, very important because people do not do that. And a lot of people who are the advocates of the scalpel bougie technique, as anesthesiologists, we are not very good at cutting the neck. We are better at doing needle and Seldinger procedures. So sometimes, in this kind of setting, there are a lot of human factor consideration. It's easy to say, just use a scalpel and a bougie. And in fact, in the Indian setting, scalpel, bougie, and tube is very easily available in every operating room. You'll have a scalpel, you'll have a 6-number tube, and you'll have a bougie to do this procedure. But when your hands are trembling and you're not able to ventilate, ask an anesthesiologist to cut, and it'll be very, very difficult to cut. So anyway, just coming to this, I'm just trying to say that whatever is the technique, you should follow this. All the international guidelines except DAS recommend that you could use any of the techniques, but make sure you transition into emergency cricothyrotomy. And what's very important is the emergency procedure is cricothyrotomy and not tracheostomy. A lot of people in the examination say, I will do a tracheostomy. A tracheostomy takes time, you need light, you need cautery, you need a surgeon, you need to take the patient into the operating room. Whereas a cricothyrotomy is very quick access to the cricothyroid membrane, which is very superficial, relatively avascular, and is easy to palpate, and that should be easy access for an emergency. And that's not the part we do tracheostomies from, but for cricothyrotomy, it should be your emergency airway access in these patients. And what's very important when you have this kind of procedure is to have a post-procedure plan. Now, this is very important. When you've had a difficult airway, don't just leave, you're able to successfully ventilate and oxygenate this patient, don't just leave him there. You must have a further airway management plan. For example, when you have done a cricothyrotomy, you can't keep that for more than 24 hours, okay? If whatever you put in a needle, or even if you put a whiteboard tube, you are very close to the cords, and there's high chance of subglottic stenosis. So you must convert this into a tracheostomy. Very important if you've had a traumatic kind of intubation, very important to examine the airway after you've established a definitive airway. Treat the edema. There could be a lot of edema, there could be bleeding, the airway might further deteriorate. So remember to keep this in mind. Monitor for complications, but don't just leave somebody who you've had a very stormy, difficult course where you had complete ventilation failure, just like that. And most important is counsel the family and also the patient later and document this. Documentation is very important because they might go for an anesthetic somewhere else, and this was a completely unanticipated difficult airway, and people didn't have any idea that this was difficult. So it's really, really not fair to do that. Whenever you have this kind of situation, whether it was a difficult mask ventilation, intubation, supraglottic insertion, do make sure that...
Sorry to interrupt you, ma'am. I'm muting everyone. And ma'am, you will please unmute yourself. Please unmute, ma'am. Yeah.
One second. I think I'd got unshared. Just 1 second. Sorry about that. Yeah. Can you see my screen?
Yeah, we can see your screen.
Okay. Right. So the post-procedure plan is extremely important following a difficult airway algorithm. So here coming to the algorithm, very, very similar. Like I told you, it's pretty similar to the Difficult Airway Society guidelines. The difference is in the terminology, in the critical language that we're using, calling for additional help, and also that the Indian guidelines have given a wide choice for emergency cricothyrotomy and not restricted it to just one technique, and subtle differences, but I will tell you what the important points are for our guidelines. So if you look at it, they also have, you can't intubate, then you go into supraglottic, you can't do that, you go into face mask, one last attempt at face mask ventilation, and if you can't do that, you go in, you go on to what they call phona. So what they use is kycophona. What we use is complete ventilation failure and emergency cricothyrotomy, and I'll tell you why in a minute. Right, so these are the subtle differences between the guidelines. This is the American Society of Guidelines, which have, the DAS guidelines were published in 2015, and the ASA guidelines have been published in 2022. And I'm really, really proud to be the first Asian member of, as a co-author of the ASA guidelines. And a lot of input from the Indian guidelines have gone into making the ASA guidelines. The ASA guidelines disregarded, they cannot intubate, cannot oxygenate. They accepted our argument about why cannot oxygenate is not appropriate terminology. If you see what ASA uses, they don't use complete ventilation failure. They can't take our terminology, but they have said cannot intubate, cannot ventilate. And they have acknowledged that ventilation failure precedes oxygenation failure. And that should be your trigger for performing emergency cricothyrotomy. We have a bit of a disagreement what cannot intubate, because we think it's, airway management is not intubation centric now, but well, that's ASA. And the call for additional help is completely an idea that comes from the Indian guidelines. And they have not called it FONA, which is front of neck access. They call it emergency invasive airway. What's very important is to have the term emergency, because this is not elective airway management. They call it invasive airway. We call it cricothyrotomy. So these are just subtle differences between the guidelines, but very, very important that the principles are the same. I would prefer the layout of the DAS guidelines. I don't like this kind of branch tree kind of pattern because it's very complicated and very confusing. The Indian guidelines are really very stepwise and systematic, like the Difficult Airway Society guidelines. But these are the most recent guidelines that have just been published in January 2022 from the American Society of Anesthesiologists. So just coming back to our guidelines, and this is what the Indian guidelines look like. And I would like to tell you that I'm not just saying it because I was a lead on these guidelines and because they're Indian guidelines or what. I'm saying that this is something that we should be really proud of, because it's the guidelines that are published in the Indian Journal of Anesthesia are one of the most highly cited articles, and our guidelines have been acknowledged globally as a very good guideline with very important points that have actually made airway experts across the globe rethink what guidelines, what we should incorporate in future guidelines. So I'll just tell you some of the unique features of the Indian guidelines. Is a big stress on peri-intubation oxygenation. Like I mentioned, it's not only pre-oxygenation, but oxygenation during attempts at intubation. That's very important. Ours is the only guideline that's talked about a threshold of 95%. So we said it's not 3 attempts. That means you fail one, do the next, do the next, do the next. Make sure that the saturation comes up between attempts at intubation. Why such a high threshold? One would have put it as 90 or so. But by the time you kind of detected this, a lot of time has lapsed. In addition to this, there is a lag time, with the pulse oximeter. So when you're looking at 95, you're actually at a much lower saturation. And that is why we kept the threshold much higher. New terminology, as I mentioned, complete ventilation failure, calling for additional help, and cricothyrotomy technique based on your familiarity and the availability of the equipment. We did not restrict it to doing a surgical cricothyrotomy. So this is the peri-intubation oxygenation, continue your nasal oxygen following the pre-oxygenation. And also the cricothyrotomy technique based on your familiarity, calling for additional help. And just coming to the other aspects is the human factor. Now, this is very, very important. Now, what do you mean by the human factor consideration? Now, when you're faced with an unanticipated difficult airway, it's not just your technical skills, it's your non-technical skills that are also very important, right? You notice whenever in India we have a situation where you can't intubate, people start to shout, ye kahan hai, wo kahan hai, ye kyun nahi kiya, tumne ye kyun kiya? We're just blaming each other, and we're not calm. We're not cool, and we're putting our stress on the other person. The senior is shouting at the junior person, the junior is shouting at somebody else. So during a crisis, it's very common to be presented with, you're getting so much information, more than can be processed. And this is what we call cognitive overload. And this impairs decision making and can actually cause clinicians to lose sight of the big picture. And then you have what you call the fixation error. That means you become fixated on a particular task. So human factor issues, in the national audit project that was done in the UK almost 10 years ago, they saw that it had contributed to adverse outcomes in almost 40% of the instances where the complications were related with airway management. So it's not only about technical skills, it's also about your non-technical skills, and human factors is a lot of, lot of discussion nowadays. And what are the latent threats? Poor communication. You've not communicated your plan prior to airway management. Okay, if I fail to intubate, what are we going to do? How often do we have an airway timeout before we start? Okay, so my plan is to intubate this patient. If I don't intubate this patient, do we have a supraglottic airway device ready? Okay, if you're not able to do that, and if you fail that, and we're not able to mask ventilate, do we have our cricothyrotomy kit? Do we have some, how many of us even think like this, right? We just think that, oh, the intubation is going to be successful. If I'm not able to do it, my senior is able to do it, right? We're not thinking. And like you say, the eye does not see what the mind does not know. And this is how the downward spiral and the de-escalation starts. So poor communication, poor training, and teamwork, right? So teamwork also becomes a problem. And then there's a hierarchy. There's always the senior, and you realize that you want to tell the senior, madam, stop intubating. You've already done 4 attempts. Put in a supraglottic airway device, but you're very scared. You're very intimidated because that is your senior, madam, your professor. You don't want to say that, right? So you have to break the hierarchy in this kind of setting, and you have to have, be able to speak up and say, no, this is wrong, come on, do this, because that senior person is only thinking about the intubation, and there is a fixation error. So if you want to avoid this kind of situation from going downward and progressing into the spiral, what you have to do is you've got to speak out and say that I think we should do this, okay, based on whatever your what you've learned from your guidelines. Now, deficiencies in equipment, like I said, people don't even have any plan for how they're going to do a cricothyrotomy. No training available whatsoever. So this is very, very important. And training for an emergency cricothyrotomy, unfortunately, cannot be trained on patients. You can learn how to put a supraglottic airway device, you can learn tracheal intubation, but you cannot learn emergency cricothyrotomy training. And this has to be done at workshops. And also there is a fade of skills. After every 9 months, you need to retrain yourself. And that is why it's very important to do courses where you learn both technical and non-technical skills of emergency airway management. Learn any one skill of how to perform emergency cricothyrotomy. It could be the scalpel bougie technique, needle technique, whatever technique. Learn one technique, master that technique so that you are prepared for this situation. Hopefully it doesn't happen, but this can be a situation. So these are the additional points that I told you, calling for help. Now, one important thing is critical language. Now, what is critical language? Critical language is the language that you use in an emergency. So there's a very nice article, a review that Nicholas Grimes and Tim Crook have written, Critical Airway, Critical Language. And we recently wrote another editorial on critical language during emergency airway. This was published in the Indian Journal of Anesthesia in March 2020. And we have questioned whether it is time to rethink the terminology. Now, it's very important that during an airway emergency, you should have uniform language. If I say something, you should understand that this is an emergency situation. We need to do a cricothyrotomy. I cannot be using different, I might say kyco and you might not understand what I'm saying. So it's very important that critical language should be uniform, and we probably need to rethink terminology. And what we've challenged is that, is it appropriate to say kyco and transition into phona? What the Indian guidelines recommend is complete ventilation failure, transitioning into emergency cricothyrotomy. And I'll tell you why. The issues with the cannot intubate, cannot oxygenate. So there's too much emphasis on intubation. When you say cannot intubate, it's not only intubation. I might have put in a supraglottic airway device and that may have failed, right? And today there are several other techniques of airway control. So cannot intubate kind of becomes redundant, okay? So let us come into oxygenation. And I told you, oxygenation is very poorly understood and very misleading. For example, when we did a survey prior to publishing our guidelines, when we asked people, what do you understand by cannot oxygenate? To some people, it meant the saturation falling down. For some people, it meant that I cannot mask ventilate the patient. So it meant different things to different people. So it's very poorly understood. And as I mentioned, in the era of apneic oxygenation, you cannot have a situation where you wait for the saturation to fall before you do a cricothyrotomy. So if you cannot ventilate a patient, by a mask or a tube or a supraglottic airway, you know the saturation is going to fall. Because if you can't ventilate, you won't be able to oxygenate. Your saturation may be preserved if you pre-oxygenate the patient well, or if you're using apneic oxygenation, but desaturation is inevitable. And therefore, ventilation failure always precedes oxygenation failure. And that should be your trigger to initiate the emergency cricothyrotomy. So these are the various things that people think, and it's misleading, and it might actually be dangerous. Because when you say, I cannot oxygenate, say I've used Thrive, and for 30 minutes my saturation is preserved, and then suddenly it starts falling, that should not be my trigger to use it. And that is why the cannot oxygenate terminology may actually be dangerous, as it may delay transition into emergency cricothyrotomy. And this is why we choose to use complete ventilation failure, because among all your 3 lifelines for ventilation, all of them have failed. And that's why the term complete ventilation failure. Then what about front of neck access? Now, why, when you say FONA does not convey a sense of emergency, right? When you say FONA, do FONA, it doesn't, nobody thinks it's an emergency. And so DAS modified this by using the term e-FONA. Now what does E stands for? E actually stands for electronic, email and, e-cigarette, etc. So that's what E stands for, right? So what does e-FONA mean? If I say do e-FONA, will you understand what I'm trying to say? So what's very important is that you need to convey a sense of emergency. The other thing is, why front? Why do we need to say front of neck? Do we ever say front of face mass ventilation? I mean, what procedure are you expecting from the back? Like maybe a cervical epidural or something? I don't know, but there's really no need for this term front. And neck access, when you say neck access, what access? Are you talking about IJV? Are you talking about cricothyrotomy? Are you talking about tracheostomy? So it's not very specific. And this is why we feel it's very important, one, to convey critical language that gives you a sense of emergency cricothyrotomy, and also cricothyrotomy, because a lot of people think tracheostomy is emergency airway management, but we must, convey very clearly that we mean emergency, this is an emergency, and we mean cricothyrotomy. So it also gives you a focus on the anatomical side. When you say emergency cricothyrotomy, everybody understands that we are going to access the cricothyroid membrane. They know the procedure and they know the sense of emergency, and why this is why we believe it's more appropriate terminology. The other very important thing that I've told you is we've discussed that you should have 5 to 6 consistent waveforms with no decline. It's the only guideline that has been talked about consistent waveform and the number of waveforms that you should use. And no other guideline has addressed this, because they just say use capnography, but how to use capnography effectively is very important. And this is really, really important. Make sure you have same amplitude waveforms and there's no decline. And you should have at least 5 to 6 before you say the tube is in the right position. So these are some of the unique features of the guideline I've already talked to you about, and it's a guideline really, honestly, we should be proud of. I'm not only saying it because we have developed it, but this is a guideline which has a lot of unique features that a lot of airway persons have, airway operators have looked at, and we will soon have an update in December 2022. Now, I'd just like to tell you one part of the ASA guideline that's very, very interesting. Now, the ASA guideline has something very, very unique. Now, when you look at the situation of unanticipated difficult airway, one would wonder that, is there a way we can prevent the situation? Now, why do we get an unanticipated difficult airway? And why is there a problem? Because you have given GA to this patient, you have given an anesthetic, you have given a muscle relaxant, right? And now you're in a situation you cannot intubate the patient, you cannot put in a supraglottic airway device, and you cannot mass ventilate the patient. Now, if you hadn't given general anesthesia to this patient, you wouldn't have any of this problem, right? So the way to prevent this is to do an awake intubation. Just do an awake intubation, and you'll never be in a complete ventilation failure situation. But of course, we cannot do awake intubation for every patient, because you have to think about patient comfort. It can be only those select few patients which we anticipate to be difficult. So something very unique that the ASA guideline, and I've been a part of this development, has done is they've given a very nice infographic. And I think this is the most beautiful part of the current ASA guideline, that how they've given a decision-making tool, that how do you decide whether to do this patient awake or asleep. So, your senior says, okay, this looks like a difficult intubation. No, this is anticipated to be difficult. So let us do awake VL, or let us do awake fiber optic intubation for this patient, right? But you should probably go about in a very systematic manner and see whether this patient is actually, should be done awake or asleep. And again, what you might go through the same algorithm and decide on awake, whereas I might decide to do this asleep. So again, it's not a fixed algorithm. I'll put you through this. The beauty of this is it's flexible depending upon your expertise, depending upon your setting, and depending upon your availability of equipment. So just to put you through this decision tree, I think this is really, really beautiful, because before intubating anyone, I go through this decision tree because I find this very useful. So if you have suspected difficult laryngoscopy or intubation with a direct or video laryngoscopy, if it is no, then you can straight away go to induction of anesthesia, right? If you're not expecting direct laryngoscopy or video laryngoscopy to be difficult, right? But if you have suspected difficult ventilation with face mask ventilation or supraglottic, so even if the intubation may be difficult, is the ventilation going to be difficult with the face mask or supraglottic airway device? So then if it is no, the other question you should ask yourself is there an increased risk of aspiration? And there are some patients who have very low reserve, especially critically ill patients who have increased risk of rapid desaturation, right? So these are the three things that you should consider. Okay, even if intubation may be difficult, today you have video laryngoscope. Is mask ventilation going to be easy or difficult? If mask ventilation is going to be easy with a mask or supraglottic airway, then I'm not worried. If they're at a risk of aspiration after giving general anesthesia, and if they are at a risk of rapid desaturation, I just give muscle relaxant and this patient will have precipitous fall in saturation. So if you have yes to any of these three things that you consider, then you must consider doing an awake intubation. So these are the factors that you should probably put yourself through this decision tree. And if the answer is no to all of this, then you can do your airway management after induction of anesthesia. So any one factor alone or in combination may actually make you think. Now, if you have someone who is a senior professor, who has a lot of expertise in airway management, in their hands, they might consider to do this under GA. But if you have less expertise, you don't have your airway equipment, you don't have your supraglottic airway device, perhaps you should consider doing this awake. So what I'm trying to tell you is this decision tree is actually flexible depending upon your expertise, what is the setting, what is the type of patient that you have, and what is equipment that you have in your operating room. And I find this very, very useful part of the ASA guidelines. People only look at the algorithm, but I think this difficult airway infographic for decision making is very useful, because a lot of time we land up with unanticipated difficult airway because the patient we should have done awake, we actually do asleep with muscle relaxant, and then we land up in a situation where we can't intubate, we can't put in the supraglottic airway device, and all of this can be prevented if you had probably done this patient awake. So consider using this decision tree, because I think this is the only guideline that is actually given an infographic and a decision-making tree, which I find very useful. Now, looking at this, the difficult airway guidelines, we've got so many guidelines for unanticipated difficult airway guidelines. So we have a project, and that is called the Puma project, which is a project for universal management of the airway. So we said, why should we have American guidelines, DAS guidelines, Indian guidelines, all the guidelines? So what the Puma project, or the project for universal management of the airway, is coming up is basically putting the principles of airway management together into a universal guideline. And I'm very, very proud to be part of the 14-member team working on these guidelines. And hopefully in 2023, we should have this out. Are they going to replace the regional or local guidelines? No, that's not the case. These will complement the guidelines because they constitute universal principles of airway management. And this is very, very interesting content that I'm sure all of you will be looking forward to. So what Puma hopes to achieve is, it's an ambitious project, of course, but basically a universal guideline, irrespective of what the age is, what culture is, what resource setting. For example, now you have a different guideline for obstetrics, you have difficult one for pediatric, difficult one for ICU. So what they're saying is, irrespective of your setting, your geography, the age of the patient, you should be able to have a universal kind of template that you should be able to customize for airway management. And very important, they've looked at the critical language and the terminology for universal use, and also taken into consideration the Indian guidelines. And these will be evidence-based guideline, and very interesting content for you to look forward to in 2023. What is the Indian contribution to Puma? Not just myself, but we've given a different perspective with the Indian guidelines. We've emphasized the huge peri-procedural oxygenation concerns, and also time to rethink terminology. Cacophobia is completely out of the Puma guidelines, and also they have taken the call for additional help. Unfortunately, I cannot reveal the content of this, but look forward to these guidelines, which will be published hopefully by the end of 2023. Dr. Monica, if we have time, actually I've finished my presentation, but if we have time, I would really like to go through one or two cases, if you permit. Just to Yeah.
We have a lot of questions after that. You can go through the cases, and after that we'll take
Sure. So I'll just go through one or two, just 10 minutes, and then we can take a lot of questions. Yeah. Okay. So I'll just put you through some unanticipated difficult airway, because I think all of what I've been doing now is very theoretical, and I'm sure it's stimulated you all and charged you all. So you should really be. I want to really test whether you're ready. So Dr. Monica, you're going to tell me the responses. Okay. So the first case is a 40-year-old lady scheduled to undergo laparoscopic hysterectomy under general anesthesia, and clinically unremarkable airway, no significant past history. And she undergoes a conventional intravenous anesthetic. So fentanyl has been given, propofol has been given, and of course she was pre-oxygenated well with 100% oxygen. And I have initial difficulty in mask ventilation. Okay, so I've not even done a laryngoscopy, and my saturation starts to fall. It's fallen to 94%. Okay, so what should I do now? Increase the depth of anesthesia and insert a supraglottic airway device? I should give a muscle relaxant, perform some maneuver to improve mask ventilation, or should I just stop everything and just put a laryngoscope in and intubate the patient, or something else? So please type your answers, 1, 2, 3, 4, 5.
So Dr. Nina, Dr. Saras, and one more has
people to participate. Okay, so just write 1, 2, 3, or 4, or 5.
Yes.
Tell me the majority.
Everyone is for 3.
Most of
maneuvers to improve mask ventilation.
So I think that's excellent. And from a PG perspective, I think that's a fantastic answer. Okay, so this is probably a PG student doing this or whatever. So what's very important is initial difficulty at mask ventilation. Okay, so your saturation starts to fall. You must improve mask ventilation. And what can you do? Maybe a two-handed technique, put in an airway, and definitely also you must increase the depth of anesthesia, because sometimes they're in lighter planes and you're not able to effectively ventilate. So give a muscle relaxant. So I would really say a combination of these three. Trying to intubate would, I think, be a little premature, but a combination of these three, but definitely perform maneuvers to improve your mask ventilation. Now, a two-handed technique with oropharyngeal airway in place overcame this initial difficulty in maintaining the airway, and the saturation now came up to 97, right? So that's exactly what was done, and things kind of improved. Now, following paralysis with vecuronium, now, surprisingly, after giving the muscle relaxant, there was increased difficulty in mask ventilation. And now the saturation starts to drop. So you've given the muscle relaxant, vecuronium, and the saturation is falling. So what will you do now? Should I perform laryngoscopy and try to intubate this patient? Should I insert a supraglottic airway device and try to ventilate this patient and bring up the saturation? And if I have a video laryngoscope, I will use this and try to intubate this patient. So what should I do? Or should I do something else? Can I have the answers?
Answer is,
there are a few
are answering number 2, insert an LMA and try to ventilate the patient.
Right. Okay, so now that's right. That's probably what I would do. So, in this kind of setting, what's important to see is the patient's saturation is now 90. Okay, it's a critical condition. And for some reason, I don't know why, the mask ventilation has become difficult after giving the muscle relaxant. So I would be very worried as to why is this patient not easy to ventilate after giving muscle relaxant. Plus the saturation is 90. Now this is a very critical setting. I wouldn't like to mess around. Okay, and definitely trying to put in a supraglottic airway device and trying to ventilate the patient. Try to bring up the saturation. Okay, because mask ventilation is not possible. So you have to use your other lifeline. Okay. So it wouldn't be totally wrong to put in a video laryngoscope and try to intubate. But at this point, my priority is to optimize the oxygen saturation, right? So that's what I would do. Now, a Procel LMA was inserted, adequate ventilation, patient saturation comes up. Okay, saturation has come up. Now, what is my option? I awaken the patient, postpone this case, okay? Or I continue using the supraglottic airway device. Third option is remove the supraglottic airway device, and my senior has come saying, now try to intubate this patient. Remember, you never did a laryngoscopy, okay? So you don't know what the laryngoscopic view has been like, right? Or intubate through the supraglottic airway device with using available techniques or something else.
So everyone has answered number 4, intubate through the LMA using available techniques.
I'm really, really happy to see this, okay? Because I would have probably done 3, remove the LMA, but the important message is with the supraglottic airway device, you were able to maintain the saturation. Do not remove this under any circumstances. If you've done it as a rescue, especially in a patient, you could not mask ventilate with the relaxant. So keep that supraglottic airway device. And if anyone could tell me what your two prerequisites are to intubate through a supraglottic airway device, if you can just put it in the chat box, how would I do it? I need 1, 2, 3, or whatever.
So the question is how to, Dr.
Intubate.
Mohan has written entry.
Yeah.
Dr. Nina, fiber optic bronchoscope.
You must have.
Airway exchange catheter.
Entry is not mandatory. That's a technique if you want to do a tube exchange, but definitely whatever you do, use a bronchoscope. Do not do blind intubation. There is a high chance that your tube might go into the esophagus. It depends on how well positioned your supraglottic airway device is, and you might completely lose the airway. So remember, always intubate through it using an entry exchange catheter or using a bronchoscope. You have time, patient saturation has come up. So very, very important point that is raised. You may even consider continuing the case using a supraglottic airway device. That's also acceptable if it's a short case and your saturations come up. Shall I go on with one more case or you want me to stop?
Sure, ma'am, sure.
One more, very quick.
Yeah.
If they say yes in the chat, I will go ahead. Okay, okay. Another 5 minutes. Is that okay?
Yeah, sure.
Okay, so this is a 55-year-old obese lady scheduled for elective knee replacement procedure. Now, repeated attempts of regional have failed. Now, earlier examination of the airway has revealed nothing abnormal was there. But following, so now obviously the spinal has failed and you've already done 2-3 times, patient not very cooperative. Now, following anesthetic induction with propofol and rocuronium, mask ventilation was very easy. Okay, so this time the mask ventilation is easy. But when a laryngoscopy was done, you get to see only the epiglottis. Okay, so this is completely unanticipated because the airway was not anticipated to be difficult, but you have, say you could just see the epiglottis. You can't see anything beyond that. So what do we do next? Attempt intubation or attempt bougie insertion below the epiglottis, or you use a video laryngoscope if available, or just use the bronchoscope, or use a supraglottic airway device. What should you do? What next?
So the responses are mixed. Dr. Nina is saying number 4. Dr. Chetan, number 2. Dr. Udaya, number 3.
Yeah.
Dr. Nandi, number 3. Use a video laryngoscope if available. I think most of them are answering number 3.
Yeah. So that's an excellent response. Okay. This patient, now remember, this is a different setting. You are able to mask ventilate. Mask ventilation is easy. Okay. So remember, you can oxygenate this patient. Not a worry. Your view is very poor. Okay. So you can optimize your view using a video laryngoscope. Of course, if available, you have to have one. Blind bougie insertion is not recommended. Okay, so you have to have at least a 2B kind of view, but you should not, because this can, be unsuccessful. You've already given muscle relaxant. Fiber optic intubation is going to take time. Supraglottic airway device not required. This is not rescue oxygenation. Mask ventilation is easy. So you're absolutely right. 3 would be the best option, where you use a video laryngoscope. And what's very important about the video laryngoscope is a video laryngoscope can give you a CL1 view, but remember, it's a camera at the end of your blade. It gives you a view, but it makes tube delivery difficult. Okay, so you must use a stillet or a bougie when you use a video laryngoscope, preferably a stillet, because you get an excellent CL1 view, but it's because you have a camera, so it's like an anterior larynx. So you may need to pre-shape the tube using the stillet. Put the stillet in, don't exceed it beyond the tip of the, tracheal tube. And always remember, when you put in a stillet, shape the tube like a hockey stick or J-shaped. This is very important because people put a stillet and they don't change the shape of the tube. So that makes no sense whatsoever. So whenever you use a video laryngoscope, especially when you use a hyperangulated blade, because that's a 60-degree wide angle view and you're getting excellent view because of the camera, but this is a very difficult intubation. It's an anterior larynx and tube delivery is really the challenge. Okay, so yes, I would go with use a video laryngoscope and hopefully the view has improved. Now the position of the patient was optimized. Now remember, it's not to optimize the view. There are 3 things that you can do. One is positioning the patient. Second is your external laryngeal manipulation. And the third thing is using tools like video laryngoscope. So try to use these. Now, what was done was the position of the patient was optimized. External laryngeal manipulation was given. And they attempted with a size 4 blade, and laryngoscopic view improved. Posterior glottic aperture was visible. And they tried to, what they did is they put a bougie, and then intubation was achieved. A bougie was inserted. But what I try to say is the complete blind If you just have an epiglottis view and no view of the glottis, do not do a bougie insertion. But if you have some glottic view, of course, you can do a insertion. I don't know whether I should go. I'll just go on one case, Monica, last one. Can I?
We have only, I think, 23 minutes left.
Okay.
So
Only 3 minutes.
this can be our last case.
Yeah. So 50-year-old female, this is a radical mastectomy, unremarkable airway preoperatively. Propofol was given, fentanyl was given, mask ventilation is easy, okay? Rocuronium is given, and it's totally unanticipated. Cormack-Lihane grade view, 4 view on laryngoscopy. So they've tried optimize the laryngoscopy, external laryngeal manipulation was given, but the posterior glottic aperture is just visible. Intubation with a bougie was tried, but that was also unsuccessful. And the saturation is now dropping down to 86. Okay, so this is completely unanticipated. So what should I do now? Put in a supraglottic, continue with mask ventilation, and use a video laryngoscope if available, or I continue the mask ventilation, and should I do fiber optic intubation at this point, or what should I do, or something else? Saturation is 86.
Maximum of them are answering number 2, continue bag mask ventilation and use a video laryngoscope if available.
Right, so mask ventilation to improve the saturation, yes. So this was a situation, but what they did in this setting was, because the saturation was falling down further as a rescue. So this was the first situation where the intubation over the bougie, 2 attempts were unsuccessful. Okay, so this is a little bit of a tricky situation, and you may not be able to mask ventilate with this trauma. So inserting of supraglottic airway device 1 and 2 would both be reasonable. What they did is that they inserted the supraglottic airway device. There's bleeding in the pharynx. 2 attempts at supraglottic airway device insertion was not possible, and they were unable to ventilate with the supraglottic airway device and also with the face mask. Now the saturation is 80. What should I do? Quick attempt with the video laryngoscope, 1 more quick attempt with the Matrix blade, 1 quick attempt with the bronchoscope, or then put in a supraglottic airway device 3rd time, or something else.
So they are answering 1.
1 quick attempt with a VL.
Quick attempt with a video laryngoscope.
Intubation.
Dr. Chetan has answered 5. Dr.
Yes.
Chetan,
I want to know what is your other answer. What is the answer? When you say other, you have to tell me what other. What is the response?
Chetan has answered Puna, front of neck.
Oh, I'm disappointed. After all that I told you, you're saying Puna. Give me a more specific term. I don't understand Puna.
It's emergency cricothyrotomy.
Yeah, I don't understand Puna.
Yeah.
It's emergency. No, so you're absolutely right. In this kind of setting, already you failed with the bougie twice. This is now, your intubation has failed, your supraglottic airway device, 2 attempts have failed. You shouldn't go further. It will cause more trauma. You already have bleeding, and the response in this setting should definitely be other. And the other over here, and the right answer, surgical tracheostomy, percutaneous, needle, surgical cricothyrotomy, or other. What is your best rescue technique? Anybody?
So it's
how many for surgical?
Okay, 3 and 4.
Yeah, 3 and 4. Percutaneous tracheostomy is an elective procedure, should never be done in an emergency. Tracheostomy can be done if you have an absolute ENT surgeon absolutely waiting there who can do it in like 1 minute. Otherwise, you should go in for a cricothyrotomy. So that's absolutely the right thing, right? So I just want to end by saying that, our plan A is very, very strong in India. We're very, very good at tracheal intubation because a lot of experience, a lot of expertise, but our plan B is very weak. If we fail, we don't realize we have to put in a supraglottic airway device, and our plan C and D is almost non-existent. So because of this, if you have that rare patient you can't intubate, we might actually have increased morbidity and mortality. But a lot of advanced training with airway management and the expert, but the initial plan A is actually not that strong, it's weak. But they know that if they fail, I have to put in a supraglottic airway device. If they know that fails, I have to maintain oxygenation by ventilation. And if that also fails, if you know that you have to do a rescue technique, this will be never event. This morbidity and mortality will never happen. So while we're very proud and very successful with our plan A, we can really be in a very grave situation if we don't want. Of course, I'm not saying you should have a weak plan A. You should be very skilled at tracheal intubation, but your plan B, plan C, and plan D need to be equally strong. So I'll conclude by saying that your bedside screening tests to predict difficult airway, we should use them, but they're not always reliable. Remember, among all the tests, upper lip bite test is the best. Be prepared to face an unanticipated difficult airway. Do your tests, so that you have some idea. But remember, any airway can be an unanticipated difficult airway, and you need to know what is the algorithmic way to proceed when you have an unanticipated difficult airway. Use of guidelines may help to manage an unanticipated difficult airway, and you should be familiar with your guidelines. But whether adoption of the guidelines alone definitely are not enough, because to avoid serious complications. So you need to focus on human factors, training in both technical as well as non-technical skills, how to react when you face an unanticipated difficult airway, team preparation, teamwork, how to be calm, how to learn to, give advice to the other person, take over the situation. So these are all equally important. So I'll end over here. There's lots more I'd like to say, but I'm sure there are questions. So thank you very much for your attention. Have a safe airway. I'll just stop sharing my screen and I'm happy to take questions. Thank you very much.
Thanks so much, ma'am. It was such a nice lecture, and we have a lot of queries pouring in. So I'll take up the first question if you allow me.
Yes, please.
Yeah, Dr. Mohammed has asked, how can we predict anterior larynx in pre-anesthetic checkup?
Can you predict it?
How can we predict anterior larynx pre-operatively and during our PAC?
Right. So the thing is that unless you do, now this anterior larynx terminology is something along with a video when you use a direct laryngoscope. So unless you do a direct laryngoscope, you cannot really predict that it's going to be an anterior larynx. Or if you have like the, the ENT, the flexible scopy that they do, the ideal, Hopkins, that can help you, but you can't really predict it at the bedside. No, you can't do that. So the way to overcome this is to use a video laryngoscope. And you know that your video laryngoscope, the meta-analysis with all the studies looking at in the operating room, I'm not talking about ICU, has clearly shown a benefit of video laryngoscopy in terms of first pass intubation success. So today we should try, and we have a lot of cheaper models that are available in India, but we should try as far as possible to completely, I would say, transition into using a video laryngoscope and use it for more and more, for not for just anticipated difficult airway, but even for your other airways. Because what's important with the video laryngoscope, you get an excellent view, but tube delivery becomes difficult. And if you want to be able to do this in an unanticipated setting, you have to practice on normal patients about how to use a stellate with the tube and how to intubate using the video laryngoscope. So I would recommend people, especially this generation, to move towards doing video laryngoscopy even in your routine cases, because there is evidence to use that. So that can completely avoid the situation and the fear of the anterior larynx.
So I hope this clears the query. The next question is from Dr. Raj Kishore. How to treat traumatic airway edema?
Yeah. So, so firstly, when this is like a very tricky kind of situation, when you have airway trauma, never leave this airway alone, because this airway can deteriorate. Okay, it can really deteriorate, and you can, this patient the patient can deteriorate as well. So if you've had any trauma and if you have a definitive airway in, you're fine, like a tracheostomy or a tube still inside, you're fine. But if you don't, you might actually have, more bleeding. There could be aspiration, there could be edema that could, actually increase. So never leave this patient unattended. You could try a course of steroids, but what's more important is to get an ENT or yourself with a bronchoscope to examine this area after a while. And if you feel that is deteriorating, some of these patients even need a temporary tracheostomy, some of these patients, or you might have to intubate them and give start anti-edema measures. So this is really, really important, because we've seen a lot of airways deteriorate post a very traumatic kind of intubation, and we just managed to extubate the patient and everything was fine, saturation was fine, but after 3-4 hours this patient is actually deteriorated. So this is a very important question, and something that needs more monitoring rather than treatment, I would say.
So our next question is from Dr. Rais. Management of pediatric surgical airway in case of complete ventilation failure.
Yeah. So there again, I didn't discuss the pediatric guidelines. So it again goes on to do a cricothyrotomy, but in children less than, so there are subtle differences. Like I said, the algorithm is pretty much the same, because of the anatomical differences in the children, in the younger children, the tracheostomy is preferred over a cricothyrotomy. Because you're very, very close. The cricothyroid membrane is very, very close to the vocal cords. So a tracheostomy is the preferred technique and not a cricothyrotomy. So there are subtle differences, and these guidelines are available for a free download on the IGA website, and you can see it, because we really don't have pediatric guidelines per se. Now DAS is coming up with pediatric guidelines. So in fact, among all our guidelines, the tracheal intubation for ICU and the pediatric was most appreciated because there wasn't guideline on what you would do in a setting where you have complete ventilation in children. So we have for different age groups. Above the age of 8, I think it's 5 to 8, then you could consider doing a needle cricothyrotomy, but below that you shouldn't, and tracheostomy should be the preferred technique.
So Dr. Mohammed has asked, how long can we keep cricothyrotomy tube, especially if airway trauma occurred during due to multiple intubation attempts?
Yeah.
And do we have to replace it with tracheostomy tube?
Yeah. So this is a very, very important question. Now remember, cricothyrotomy is an emergency rescue oxygenation. It is not a permanent technique. So it depends. I might do a cricothyrotomy. I might oxygenate this patient. This patient starts spontaneously breathing and is fine. I remove that needle or I remove the cannula. I don't need it anymore. But say I'm in a sitting situation where say this is an ICU patient. I was intubating the patient with a pneumonia, and now I was not able to secure the airway. I failed with all the steps, and now I've come to a cricothyrotomy. This patient needs a definitive airway. So this cricothyrotomy, if you need that airway for longer period, not more than 24 to 48 hours, right? Because a high chance of subglottic stenosis. So remember, it's a rescue technique. Normally for a tracheostomy, we never go through cricothyroid membrane. It's not a preferred site. It's just easy during an emergency and safer, easier for an anesthetist to do, and less vascular. And that's the reason we prefer the cricothyroid membrane. But if you need to have a definitive airway for a longer time, then you should convert this into a tracheostomy. For example, if the patient is going to receive ventilation for something, like that. But if it is just a temporary thing and the patient is fine, then you just remove it. You don't need to change to a tracheostomy.
So someone has asked, the name is not visible. So if after the neuromuscular block, we have complete ventilation failure, and somehow we are not able to assess the front of the neck, that is, we are not able to do the emergency cricothyrotomy. So what are the options?
Right. So yes, this can happen. Most of the time, it's after giving the muscle relaxant that you face the situation. So remember, even I used to get very scared because I used to wonder, why are they saying muscle relaxant? Like I don't want to give the muscle relaxant when I can't ventilate. But often I'm able to give the muscle relaxant and I am able to ventilate. So your chance of success is highest when you give the muscle relaxant, right? And as I told you, you are in a complete failed situation. Your chance of successful supraglottic is best when you give a muscle relaxant. Your chance of intubation is best when you give a muscle relaxant. So whatever lifelines you have work best with the muscle relaxant. Now, despite that, if it fails, well, not being able to identify the cricothyroid membrane, what you could do is you could use ultrasound. A lot of times when what we do is we palpate the neck, especially if you are anticipating a difficult airway, you palpate the neck and we do what we call the laryngeal handshake. The larynx is a rhomboid structure. So you move the larynx from side to side and with your index finger, you move downwards and you palpate. So usually below the Adam's apple, if it's a male patient, very easy to identify, or you just palpate and you identify the hyoid, thyroid cricoid, and you can palpate that groove. So especially in women who are obese and short-necked, it's difficult, but you can do a laryngeal handshake. If you have an ultrasound machine and the probe, you can actually do an ultrasound, identify the cricothyroid membrane, and mark it. So when we have an anticipated difficult airway, especially, we mark this. Sometimes we even put a needle in and keep. Okay, so these are some things we can do because you should look at the neck when you're anticipating. Unanticipated, now if you can't, then you could use ultrasound to identify it. Or then if you have a surgeon, then you have no option and you can't then you can just do a transtracheal needle puncture and or do a tracheostomy if you have a surgeon available. Yeah. The point I'm trying to make is between cricothyrotomy and tracheostomy, you should be doing cricothyrotomy. The unfortunate part, what anesthesiologists do when they fail upper airway, is they're just waiting and waiting and waiting for the surgeon. They're saying surgeon ko bulao, tracheostomy. So that is not emergency airway management. You and I should be doing a cricothyrotomy, putting that needle in, doing a scalpel bougie technique while waiting for the surgeon. And then he can come and convert it into a tracheostomy or help you. But we should not be delaying ventilating and oxygenating this patient because we are unable to do a tracheostomy. So the important point is that emergency cricothyrotomy is rescue, neck rescue, and not the tracheostomy in an emergency situation.
So he has specifically asked about the thyroid swelling. If there is a large thyroid swelling in the front of neck.
Now, this is really a challenge, and these are the kind of cases we usually have these in Tata Memorial Hospital. And a lot of time there are nodes there is deviation of the trachea, and these are the case where pre-operatively, because this is anticipated, isn't it? You know that mask ventilation may be easy, intubation may be easy, but if that is difficult, your neck rescue is going to be difficult, your cricothyrotomy. So you have to identify your cricothyroid membrane in advance and mark it, and I would say even put in a needle or have a surgeon stand by if you have to do this. And sometimes in these kind of settings where you cannot do even a tracheostomy in these kind of patients, then you can use what a rigid bronchoscope can be used sometimes, because if you have a very big thyroid mass that is falling and you have a complete ventilation failure because of a different setting where you have complete collapse of the trachea, especially long-standing thyroids with tracheomalacia. So what happens is you can't do anything. You can't ventilate, you can't do anything. The whole trachea is kind of collapsing after giving the muscle relaxant. Of course, you should not have given the muscle relaxant, but if you did and you face this situation, then you can use a rigid bronchoscope, which is like a metal endotracheal tube. You can just stent the trachea, and it has a ventilating port through which you can ventilate this patient. So it's like a metal endotracheal tube. You can look at it like that, and you can just bypass this complete obstruction due to tracheal collapse.
So our next question is by Dr. Arjav Desai. Can you can you go over awake intubation? Is it only via bronchoscope, or is there any? He's trying to ask whether there is any other method of awake intubation.
Oh yes, there are 4 methods of awake intubation. So awake intubation, is done by using a flexible bronchoscope. You can do a awake video laryngoscopy. You can do a blind nasal procedure, or you can do a retrograde intubation. So there are 4 ways. Now, I would discourage you completely from doing a blind nasal because it's a completely blind procedure. And in the era of having a bronchoscope, you should not do this blindly. Retrograde intubation also can be done. We teach everyone how to do retrograde intubation. All our graduates learn how to do it. Say you have a patient with complete trismus, your bronchoscope doesn't work, you should at least know how to do it. Now, after preparing your airway, you can use either awake video laryngoscope or awake flexible bronchoscope. So among the 4 techniques, these are the 2 that I would recommend. And remember, people think because of video laryngoscopy, you don't need to use a flexible bronchoscope. That's not true. If I have a patient with complete trismus, how am I going to do the video laryngoscopy? I will need. So you need expertise in both these techniques, not just one. And video laryngoscopy can never completely replace a flexible bronchoscope for awake intubation. So I would say you would need to use both. And between these 4, prefer the techniques that you can do under vision because they're safer techniques: awake VL and awake flexible bronchoscopy.
The next question is, can PUMA guidelines be applied to a hospital where high-end equipments are not available?
Say that again. Which guidelines?
Puma guidelines, the guidelines you discussed.
Very interesting. Like I said, I can't reveal content, but the Puma guidelines are applicable irrespective of geography, irrespective of context, irrespective of, they are universal principles. They're actually a platform for, not saying that, okay, I live in India, so I'll use this guideline. I have a bronchoscope, I don't have a bronchoscope. It's not like that. So it's universally applicable principles. So it's more about what is the thinking as your airway deteriorates, as you're not able to secure the airway. It is not about just tools and technology. And, we have to get out of this mindset that I don't have a video laryngoscope, I don't have a bronchoscope. We don't have it not because it's expensive, because of lack of awareness and lack of will. You'll spend a lot for a holiday, won't you? But you won't invest in, video laryngoscope. And we have very cheap video laryngoscope available now in India, which are very good quality. So it's really a question of, making the equipment available. Like when we put capnography in our guidelines, we were heavily criticized. People said, oh, everyone doesn't have capnography in India. But using the guidelines, a lot of institutions were able to get capnography. So when you have these kind of recommendations and guidelines, you can go to your administrator and say, look, this is what is recommended. We should be using capnography today. This is the gold standard. So let's make it available. So it's something like that. It's availability of equipment is something, and cost is something very, relative, and we shouldn't sort of use that. But coming to your question, Puma guidelines will be applicable for all contexts and all settings.
They're asking which video laryngoscope is best according to you.
So I would say none of the video laryngoscopes or all of the video laryngoscopes. I'm not favoring any company. So there are 3 types of video laryngoscopes. Okay, so you have your video laryngoscopes, which are like the Mac blade. Okay, so those are easier to use because it's just a direct transition from the conventional DL to the VL. So what we do, we actually make our trainees use the video laryngoscope like a direct laryngoscope without looking at the screen. I cover the screen and I say, okay, you will learn to intubate like this. And then we also make them do it. So, you can transition easily between the two. You can teach them direct laryngoscopy and you can teach them video laryngoscopy. The other ones are the channeled video laryngoscopes. Okay. So they they have a channel where you can put your tube. So essentially the problem that I told you is about directing the tube in the direction of the view, because the camera is giving you an excellent CL1 view, but you're not able to pass the tube, right? And the third one is a hyperangulated blade. So they are not like the Mac blade, they are hyperangulated. And these are to be used for difficult intubation because they give you a more wide angle view. And especially when you have a very anterior larynx, they can give you a better view. Now, when you use a video laryngoscope, I would urge you to use a stellate. Even when you're using a Mac blade, with a hyperangulated video laryngoscope, 100% you should use a stellate. The mistake that people make is they use a video laryngoscope and they think my intubation is going to be easy. Remember, video laryngoscope gives you an excellent view. It makes delivery of the tube difficult because it's a camera giving you an excellent view. We still don't know what is the best view to facilitate easy intubation. We don't have the answer to this question. We have a camera that can give you the view, but it's important to use a stellate and not a bougie really, because what the bougie does, when you have a partial glottic view with a direct laryngoscope, you put in a bougie and then you railroad the tube over. Whereas a stellate serves a different purpose. When you have a very nice video laryngoscopic view, you put the stellate in the tube and you shape it like a hockey stick, shape it like a J-shaped. This is important. People put the stellate and they don't pre-shape the tube. And then you see how easy it is to deliver the tube. So this needs some practice, some training. But I urge you to use a stellate with the video laryngoscope, definitely the hyperangulated, but even the regular video laryngoscopy, unless it's a channeled one, which of course doesn't need. So I would say it doesn't matter which vendor, buy any one video laryngoscope, what you're familiar with, what you're comfortable with, and train to use you and your entire team to work with it. And that's the best one that works for you.
So Dr. Chetan is asking, can you tell something about Ludwig's management of Ludwig's angina?
Yeah, so those kind of patients, or these kind of patients look like easy intubations, but we're very, very careful because these can actually deteriorate, intraoperatively, especially if you puncture it or there's some, aspiration can be there. So these would definitely be, this is an anticipated difficult airway, not an unanticipated one. I would choose to do this using a flexible bronchoscope because then I could also examine the airway. And I would like to intubate using a flexible bronchoscope for this kind of patients. But this comes in the category of anticipated difficult airway, when you have Ludwig's.
Ma'am, now I would like to, I'll allow the participants to unmute themselves and they can ask the questions directly.
Sure, happy. I hope we're not doing the wrong way.
Please introduce yourself.
Yeah.
So any questions?
Madam, can you hear me?
Yes, yes.
Yeah.
My name is Dr. Neelam. I just have a question. You said use a stellate when you intubate with a video laryngoscope.
Yes.
Can you, instead of the stellate, can you use a bougie and put the tube over that?
Right. So
Is
this
that
is a
also
very, very good question. Often when you see someone, especially with a hyperangulated blade, understand that you're getting an excellent view. But when you put in that bougie, unless it's one of those newer bougies where you can, you have this kind of lever where the tip can become, can go move, where the tip moves. But I don't think you're talking about that kind of bougie.
No, I'm
talking about a regular bougie. What happens is you will see this video laryngoscopy be done and you will see the bougie is slipping down. Bougie is not going there. With a direct laryngoscope, your line of vision and the passage of this tube is in the same plane. So there's no problem. What you see is the way in which your tube is going in. With the hyperangulated blade, it's actually an anterior larynx, a difficult intubation, and you're getting the view with the camera. So the larynx is actually anterior, but your line in which the tube or your bougie is going is not the same. So it's really frustrating. You get a damn good view, but your bougie is slipping down and going into the esophagus. It's not going into the trachea. And that is why it is extremely important with a hyperangulated blade, you need to use a stillet in the tube, not a bougie. You need to use a stillet. This is one place where you need to use a stillet. And this is the mistake people make. They say, I have a video laryngoscope, I used it, but I could not intubate. Video laryngoscope made the intubation more difficult. It's a question about the knowledge and the training. So you need to use, so I actually recommend even using a stillet with any video laryngoscope, because often you're getting a more superior view and your tube is not going in that direction.
Okay.
But hyperangulated, definitely.
Particularly with a hyperangulated, use a
So you get the
stillet.
difference. You get the difference between the bougie and the stillet because they serve two different purposes. The stillet is moving your tube more anteriorly, whereas the bougie is just helping you like a conduit when you have a partial rhotic view. This is not the problem with video laryngoscope. You have a great view.
Yes. Okay. But with your regular video laryngoscopes, like the Mac blade, using a bougie should be all right if you don't use a stillet?
With the Mac blade, you can use either nothing, or you can use a bougie, or you can use a stillet. But I still encourage people to use a stillet because a lot of people are not very familiar. They don't know how to pre-shape the tube. They just put the stillet in and just bend it and that's it. And also remember that the tip of the stillet should not go beyond the tube, so you should bend it at the top because that can cause a lot of trauma. So that's also another thing that you have to take into. Careful, yeah.
So you put in the stillet and you angulate the tube in such a way that just the tip is the J shape, right? That's what you mean, right?
Yeah. J-shaped or hockey.
Hello.
Hockey, yeah, hockey. Thank you, ma'am.
Hello, madam.
Yeah, hi.
I want to ask whether suxamethonium will be justifiable to use in case of difficult intubation undiagnosed or known case.
Right. So
why not instead of using long acting?
No, I would say either is good. A lot of people do prefer, but remember, suxamethonium acts very rapidly, but it still takes time to come out of suxamethonium, right? You don't come out of suxamethonium so quickly. It will still take another five minutes at least. So this is one of the, and if you're in a situation where you cannot intubate and you also cannot ventilate and you're complete ventilation failure, you're actually better off with the longer acting. Because if you're transitioning into the otherwise you see when you try to insert a supraglottic airway device, patient has come out of scolding. So nothing is right or wrong. Nothing is right or wrong. You can use either, but you're not wrong if you use a long-acting laxative.
You can repeat scoline for thrice.
Just give a long-acting. See, you have to think about what is your option. Now, if your patient is you're not able to mask ventilate, your patient is desaturating. By not giving a muscle relaxant, what is your next option? The saturation is falling. What are you going to do? Right? What you're going to do? You're not able to mask ventilate. If you say, I won't give relaxant because, I'm very worried. Even to put in a supraglottic airway device, your success will be more if you give the relaxant. So better to give the relaxant. Whether you want to give short acting or long acting, of course, that's your choice. But you're not wrong if you give a long acting. That's what I'm trying to say.
Okay, thank you.
Any more questions?
Any more questions?
One more question. If you are putting stillet, then how you will thread the ET tube?
Yeah.
Over that, because length is very less in stillet.
So this is very, very
compared to bougie.
So stillet is not meant for railroading. Okay. Very, very fundamental point. So the tragedy is people use stillet and bougie, but they don't use it effectively. Stillet is only meant for pre-shaping the tube and directing your tube anteriorly, right? So bougie is more than double the length because it's meant for railroading. It actually enters the trachea. The stillet, you keep it at the vocal cords, okay, right here. And then when your tube, it is directed your tube towards the cords. When you're at the cords, you tell your assistant to remove the stillet. Never enter the trachea with a tube and stillet, with the stillet in place. So the stillet has to be removed because it has served its purpose of directing the tip of the tube, through the cords. Because if you go in with a stillet, you can cause trauma. Unlike the bougie, which is flexible, this is just meant to anteriorly divert the tip of the tube. So don't intubate with the stillet. The moment the stillet is at the cords, you remove the stillet and then you push the tube further inside. Is that clear?
No, I just want to know.
Yeah.
In hyperangulated video laryngoscope, you asked to put stillet, not the bougie.
Right.
Once I put stillet, then how I will put tube?
No. You don't put the stillet in the trachea. You put the stillet inside the endotracheal tube.
Okay.
So you put the stillet inside the Oh, sorry, I was not clear. Bougie goes without the tube, but the stillet goes inside the endotracheal tube. So I'll just clarify it. I think there's some confusion. So the stillet is not double the length. It's a little more than the length of the tracheal tube. It's a little stiffish structure, though it's flexible. You put it inside the endotracheal tube. Do not go beyond the tip of the tube. The moment it has reached the tip of the tube, you bend the part on top so that it doesn't go in any further and you don't cause trauma. Then with the stillet inside, you shape the tube like a J shape or a hockey stick shape, and then do a video laryngoscopy. Do a regular intubation, but don't intubate. Put the tip right at the cords, and then tell your assistant to remove the stillet when you're at the cords, and then push the tube. Is that clear, madam?
Yeah,
Ma'am,
yeah.
what about the stuck stillet?
Sorry.
Yeah.
Yeah.
The stillet is getting stuck inside,
That
and you cannot remove the stillet.
So be very careful. A lot of operating rooms, I still see these very, very traumatic metal stillets. Please do not use that. Okay, use the plastic ones or the rush ones or whatever. I'm not recommending reusing, but a lot of people reuse. But please don't use those horrible metal stillets because they cause a lot of trauma, and lubricate it. Okay, so don't just put the stillet inside. Put some jelly over the stillet. Make the biggest tragedy can be the stillet stuck inside the tube and you're not able to remove it, right? So then you just take out the tube and maybe change the tube, put another stillet. But yeah, this can be a problem sometimes, especially when you reuse the stillets a lot.
Ma'am, any option other than scoline for difficult airway that is the borderline unanticipated difficult airway?
See, unanticipated means
we are not sure whether we'll be in or not.
So that is an anticipated. When you're unanticipated means मैंने propofol दिया, मैंने vecuronium दिया, सब कुछ दिया, now I can't intubate, I can't ventilate. That is unanticipated. No? When you anticipate, obviously you might do awake, you might choose to use only scoline, whatever you do. But we are talking about unanticipated. What we're really afraid of, the airway looked normal, you wanted to give a full anesthetic, you've given muscle relaxant, and now you're in a difficult situation.
Okay.
Yeah.
Dr. Gaurav, you can unmute yourself if you have any question.
Sure.
Hello, madam.
Yes.
Highly, I'm very much thankful to tell about the J shape, making the tube J shaped, because half of the time you will be successful in tubing. Very simple.
Are you asking?
Making the tube in the J shape is highly useful technique, simple technique.
So, people, 90% of people use a stillet without pre-shaping. The goal of the stillet is to pre-shape the tube, to move the tip anteriorly. If you're going to keep the same curvature and keep the stillet inside, you have not achieved anything other than making the tube more stiff. So you have to pre-shape the tube, move the tip more anteriorly. See, J shape, hockey shape is just so that you understand in your mind that you have to move the tip more anteriorly. But if you don't pre-shape the tube with a stillet, it doesn't serve the purpose of using a stillet. There's no benefit. So that's a very important point. Even I didn't use the stillet correctly until I started to, learn from others how to use the stillet. But very important points brought about stillet getting stuck, putting stillet in trachea, how far to go, how to shape. I think these are very important points that have been brought out.
Hello, excuse me. I have a question too. I'm a retired anesthetist.
Yes.
I use AirTrack for video laryngoscopy for most of the cases. I can't understand how J-shaped stillet can get into the channel.
No. When you use
not for channel,
it is not for channel. Like I told you, there are three types. You have either the MAC blade, or you have the hyperangulated blade, or you have channeled. Now, channeled is to overcome this problem with moving the tube anteriorly. So, in the direction of the camera, in the direction of the view, if you've seen a channel video laryngoscope like you're using, madam, you are already railroading the tube. You're putting the tube into the channel. So you get the view and the tube moves in the same direction as the, so you don't need to use any stillet or bougie when you're using a channel video laryngoscope. You're absolutely right with what you're doing. Yeah.
Right, thank you.
So I think we'll take up a last question and then we'll conclude the session.
Sure.
Any more questions? So we come to the conclusion of an excellent
I
talk.
think there was one hand up. Somebody put their hand up if there is a question.
Okay. Dr. Gaurav? Okay, you can unmute yourself, please.
I have a question. Sorry.
Am I audible?
Yes.
Hello?
Yeah, you're audible.
Should I?
Dr. Gaurav, please go ahead.
Yeah, I wanted to know, like, if we have put in an LMA and suppose we don't have a video laryngoscope with us and we face difficult intubation, can we just insert a lower size tube through the LMA only?
Yeah. So very good point. See, no, you didn't tell me, did you put the LMA as a rescue or was that your primary anesthetic? What was
it? Was a primary anesthetic. I was, and later on when I found difficulty ventilating.
Okay, so you put in the supraglottic airway device and you can't ventilate the patient.
Yeah, suppose we are not able to ventilate.
So that is your first attempt. You remove it and either you change the supraglottic, put another size, put another type, or
try those things.
Yeah.
Try those things, and after that also, if we are not able to ventilate the patient.
Why ventilate? With the mask you're saying, or with the supraglottic?
With the supraglottic.
Yeah. So if you're not able to with the supraglottic and you've already done your 3 attempts, don't go further. Remove the supraglottic, do mask ventilation, regular mask ventilation.
Yeah.
Bring up the saturation.
I got your point. We can do mask ventilation. We tried that, but suppose after that, after intubation also, like direct laryngoscopy, we are not able to see the.
Then you can use a video laryngoscope. Of course, you can use a video.
I told you that earlier also that if we don't have a video laryngoscope, what I did was I've encountered this situation and I inserted the LMA and I inserted a lower size tube through the LMA.
So this is fine, sir, to put a lower size tube, but you should do it with a bronchoscope. You should not do it without, because
that's
you can
true.
put you're lucky if it went in the trachea, but a lot of time it can go in the. So
Yeah.
to remove that LMA, you were with a patient who you could not ventilate, who you could not intubate with a DL, and now the supraglottic airway device which helped you bring the saturation up, you've lost that also. So and especially one LMA with which you can't ventilate is one that is not properly positioned. So unlikely that your tube will go in successfully through that. So the point I'm making is that if you use your supraglottic airway device as an anesthetic and it's not working too well, you remove it, you can put in a VL and try to intubate. But if you put in a supraglottic airway device when tracheal intubation has failed, with a VL, DL, whatever it has failed as a rescue, in that setting, do not attempt blind intubation. Remember, you have time. You don't have equipment, get the equipment. Patient saturation is fine. Patient is all right. Muscle relaxant, supraglottic airway device, saturation is fine. No hurry to remove that supraglottic airway device or do blind intubation. Get the equipment if you don't have it. Get the expert if you don't have it. You are not justified today to take out a definitive ventilation which maintained your oxygenation and caused deterioration of the patient. So patient safety is paramount with airway management today. And that's the most important message. That is not about heroics and I could do it and I managed and somehow I got the.
Yeah, I got your point.
Yeah.
But just I wanted to know, has anybody tried it out?
Many people do blind intubation. Many people, but it should be discouraged.
It should be discouraged. Fine. Thank you.
So like all good things come to an end. We can listen to you endlessly, ma'am, but we have to conclude our session now.
Thank you.
So we hope we get another chance to listen to you. So with this, I thank you, ma'am, and I thank all my partners.
Thank you very much. I say thank
you. Over to you, sir.
And thank you everybody for the patience. I hope this was informative and useful. Thank you.
Definitely, it was informative, Dr. Sheila Nainan Myatra, and I can understand that you have been continuously speaking for around 2 hours now. Have a good cup of coffee, and thank you for sharing your knowledge and experience with all of us. We hope to see you soon for another class on this platform.
Thank you so much. Thank you, everyone.
Thank you, sir.
Thank you, ma'am. Thank you.
See you all next Monday for another ISA online PG class. Thank you very much.